Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi, welcome back to Unraveled. We have a really interesting discussion today. I'm here with my colleague and friend, Dr.
Eileen
Ruhoy.
Hi. I never know if you're going to actually say my name or you're
Right,
going to leave it up to me to say it.
So we want to talk about the immune system today. I was just saying to Eileen before we started that we've spent a lot of time over these episodes. How many episodes now? 30?
I haven't counted.
Well, a lot of
episodes.
episodes.
I no longer label them by number.
And to some degree, we've focused on, this is probably not the right way to say it, but the easy stuff, meaning POTS and how to diagnose it, always think about it, always look for it, how to treat it, SIBO and mast cell activation. And I don't mean to say those are easy, but they're sort of obvious once you know about them, okay? But it occurred to us as we were talking about what to do today that the real foundational issues here are the immune system and its dysfunction and the mitochondria and its dysfunction. And we've talked some about the mitochondria, so today we're going to talk about the immune system. And we'll start out with discussing what is the immune system and what are its roles, and are there ways we can support it in order to help manage these illnesses. So we'll start there.
That's a good introduction. Well, I think it occurred to us that, we do a lot of immunosupportive therapies. We do a lot of immunosuppressant therapies, and I think we want to focus more on the immunosupportive because those are the preferred means of treatment, certainly initially. Obviously, if you have to go to the immunosuppressant for various indications, then you do. But if you can start with the things that are more immunosupportive and don't suppress the immune system, that's preferable. Of course, I'm referring to things like IVIG, which is a very commonly prescribed immunosupportive therapy, and as well as then plasmapheresis is sort of the same. And those are the two treatments that historically we've always used for autoimmune diseases, and it's well documented. FDA-approved treatments, did it all the time, in neurology. And so it's only now that we're using it, not only now, but now it's only now for me that and for you, that I'm using it for more non-classical indications. And so I think that this patient population maybe doesn't have a great understanding of why we're using it and what it is and what it can do and what we're trying to accomplish and all of the nuances about it, by the way, which are, IVIG, it's not just like you write a prescription and then you send the patient on their way, of course. You have to get
tortured by the insurance company.
All right. Without torture by the insurance company, then really what's the point?
Right.
So do you prescribe a lot of IVIG?
I have in the past. I've cut back. Partly, honestly, because I'm so sick of fighting. It takes so much time. I get so angry. But I would certainly do more. If it was easy to prescribe, I'd be doing it all the time.
So what do you do instead?
So I would actually like to step back a little.
Okay, sorry.
Okay, no, that's okay. Because I see IVIG and plasmapheresis as a different category of immune support. Mm-hmm. Because the reason we're giving them, and we can go into this in detail, is the way they function is that ultimately they indirectly boost the immune system or raise its competence, okay? Mm-hmm. But I would like to start at is there anything else we can do to improve the competency and efficacy and strength of the immune system without, in effect, removing things, which is what TPE and IVIG are doing, if you think about it, right? And the reason I want to focus on this and the whole thing is, you and I have talked, and I've done a lot of reading and all this stuff on anti-aging longevity and the theories behind it. It's why I got involved in rapamycin. And at the end of the day, there's a lot of stuff out there, pillars of aging. But at the end of the day, it's about the immune system. And that as we get older, our immune system functionality declines. And with that decline, the diseases of aging increase, meaning chronic inflammation, which then leads to the diseases. And I think it's very similar in our patients. They have a altered dysfunctional immune system, which is maybe similar to what happens in aging, and that allows all these things to occur or facilitates it. Or maybe the things occur first and knock it down. I'm not sure which way, obviously. So I think there are ways to intervene before the fancy, expensive drugs and interventions. So I would rather start there and then work our way to IVIG and TPE and certain other things.
Okay. So are you referring to more like mast cell management meds and those kinds?
Well, in a sense.
Or lifestyle or supplements? I mean, or all of the above? Okay.
Right. So first, deal with all the causes of chronic inflammation in our patients.
Right.
And really, we've spent 30 episodes. That's what we've been talking about.
Right.
I mean, if you pull back and think about what we've said in every episode, we talk about a specific pathology, but at the end of the day, we want to tame that pathology, reduce its inflammatory effects in the body, which ultimately should improve the immune system. So yes, all of that, that's in my mind one of the reasons we spent 30 or whatever episodes it is doing that first. But then there are the sort of mundane things, okay? Like, and we don't have to spend a lot of time on this, but diet.
Right.
Okay. I mean, there's just no question. The literature is overwhelming on the adverse effects of a bad diet.
Mm-hmm.
And by bad diet, I mean high carb, high processed foods, high fat, versus whole foods and less meat and all the other things.
A study just came out actually that showed that the higher intake of fruit, you have more gray matter in your
exactly.
cortex.
I saw that.
Did you see that?
Yes,
Yeah.
I did.
So you're right. I mean,
and study after study says
study,
that about
I
meat,
agree.
about meat products, and
I
how
agree.
that speeds the development of cancer and just everything. Okay, I don't want to get into the politics of it. We're just talking about the things. Okay, so diet, obviously. Exercise is a biggie, and if you read the literature and follow it, the one constant that never changes is the role of exercise in creating a healthy immune system and decreasing the chronic illnesses of aging. It's remarkable. And it's not just people saying it. There is study after study after study after study that shows that, and including things like walking 10 minutes a day can make a difference. The reason I'm bringing it up is not to upset our patients because they can't exercise. It's that it really hits me. That's part of the problem for them. That's one of the reasons I think their immune system is dysfunctional, and they're not able to not create, but nurture the benefits from exercise. So I don't have an immediate solution for that, but I think it's an important starting point to think, what can we do to create the benefits of exercise without exercise? What are the mimetics of exercise? Enter things like rapamycin, which we'll come back to.
Right, and there are some other thoughts and ideas that I've had with regards to trying to simulate exercise for these patients.
Yes.
But I also make them as goals for some of these patients.
Yes,
and
for sure.
Of course, the goal is not that you need to run a marathon. The goal is that you can do at least this, and it's just sort of the bare minimum of movement.
Right.
But there are some ways that I've thought of how I can simulate it. So.
Right. So similar to exercise and similar to the frustration for our patients is sleep. Study after study.
Study after study. I mean, sleep is so critical.
Good, refreshing sleep helps your immune system. And I understand our patients don't get that. That is probably the single most common complaint when you interview a patient in the beginning is, I don't sleep well. Yeah. I wake up unrefreshed. It's part of the definition of ME/CFS. So again, I think sometimes when I say these things, it's upsetting for a patient to hear. You're telling me I don't sleep well, and that's part of the reason I'm sick. But in effect, yes, it is adversely affecting our immune systems if we don't sleep well. So how can we help in the realm of improving sleep disorder? We can do sleep studies. We can talk about position. We can talk about sleep aids, CPAP and appliances and things like that. There is a place for medications, for sure.
For sure. Sometimes the medications just sort of train the reticular activating system to sort of understand the whole sleep-wake, to sort of retrain it. It uses neuroplasticity to retrain that circadian rhythm.
Right.
And once it's trained, you can start to wean off those sleep aids.
Right.
So they have a role, in my opinion.
And for our patients... For our patients, they're sort of stuck in a vicious cycle.
They are.
They can't exercise. They have to spend a fair amount of time resting, not physically active. So it's not a surprise they might not sleep so well. And again, I don't have a perfect solution, but I think we don't spend enough time thinking about that and trying to address it and associating it with the pathology that ultimately is.
No, I agree. And I think about the things that we do, for example, in hospitalized patients when they have certain, cognitive impairment, dementia patients. There are ways of simulating this day, night, this dark light. I mean, I always say, and I think you've heard me say this a million times, that we so focus on the sleep aspect of the poor sleep. But we truly are a circadian rhythm being. Every cell has its own circadian clock. And so I think sometimes when I focus on the wake part of that 24-hour cycle, which is not technically 24 because you take into account daylight savings times, which I still don't understand. But if you take into account the wake part of the cycle and you set up a certain routine, it does set you up for a good sleep part of the cycle. And it does. It doesn't happen overnight. It's no pun intended. That doesn't even happen in a week. But if you do it consistently, there is definite improvement in sleep. And I think that's important. And one of the most efficient means that I have found that if I can get a patient to do it well, consistently enough, is that if you get outside and get morning light, so the sun is in the sky at a certain angle before 10 a.m.
Right.
And if you can just stand on your porch, stand out on your street.
You don't even have to stand. Bring your chair outside. I mean, if you're in a place with decent weather, bring it outside.
You're absolutely right.
Because if the patient will say, well, I can't stand, I get dizzy.
Right.
But the light still is valuable.
The light is still valuable. And so that angle is picked up by the eyes, which sends a message to the brain that says, this is a brand new day. Right. And it helps the brain sort of reset itself. Like, okay, this is the start of a day. And then it leads into the night. And over time, just doing that, even one thing alone, over time can improve just your ability to fall into slumber. Yeah. And then, of course, we talked about how important sleep is in one of the previous episodes. But again, our patients have neuroinflammation. They have neuroinflammatory responses. I mean, they have systemic inflammatory responses. The lymphatic system, which is meant to cleanse the brain, I hate that word, but cleanse the brain, really is not that efficient unless you're staying in restorative sleep stages long enough, right? So sleep is critical for that function, but importantly, you don't have to focus on the sleep necessarily, or you should focus on the sleep, but also focus on the wake part of the cycle. And so that morning light is probably one of my more favorite tips that if I could just get patients to do you sort of have to do it regularly. So all these things that are non-pharmacologic, that are more, conservative in nature in terms of recommendations, more lifestyle kinds of changes, really have to be done consistently for them to be effective. And I think that's problematic for our patients.
It's very difficult.
Many of them just are so fatigued, can't get out of bed,
or they're light sensitive.
Or they're light sensitive, exactly. Right. And by the way, it doesn't have to be bright sun, right? As long as it's light outside. Right. I mean, here in Seattle, it's cloudy all the time during this time of year.
It's not
but as long as it's light, I know. Right, exactly. So I think you're right. I mean, we have to focus in on these seemingly like simple things, but yet hard for many of our patients, but can have great yield.
Yeah. I think it's enormously frustrating for patients because I think they realize it. Yeah. And I suspect when people listen to this, they're going to say, well, yes, but I can't do it.
Right.
But somehow we and the patients, need to figure out ways to try to inch their way down that, help.
I mean, so for example, when I have a bedbound patient, and I've had patients where I've made visits to their home and they were bedbound, and so I would implement where I would have the family open up the curtains, in the morning to get that light inside the room, and to close the curtains, of course, when the sun goes out. We're supposed to go to sleep with the sun and wake up with the sun. Obviously, our modern culture doesn't allow us to do that.
But it's just to emphasize.
We do that in the hospitals. What I was bringing up when I was saying about.
Well, also they wake patients. You 50 times a night in the hospital. So, but it's also that the circadian rhythm is keyed into our hormonal rhythms.
Yes.
So there's a reason cortisol is at the highest in the morning.
Excellent point.
We need to have our high levels so we have metabolic energy and can go hunt animals and do the fields. I mean, that's real. It's all evolution. Right. And so it again, it's another one of these potential vicious cycles. If people are not getting that light exposure, not able to wake up early, then their cortisol levels in the morning drop, which makes it feel even worse. And somehow we have to address those issues.
Right.
And treatment helps. I mean, cortisol, people think of steroids as immunosuppressive, but inadequate levels of cortisol, I'm going to try not to say adrenal fatigue and not say adrenal insufficiency, but a disorder of the orchestration of that diurnal curve, that becomes immune suppressive. The person gets worse.
Absolutely.
Conversely, a little bit of hydrocortisone helps people wake up in the morning, and that is the beginning of a potential cascade of improvements, immunologically and even
so many
sleep.
patients feel so much better with a little bit, and a little bit.
Yeah,
I mean,
tiny
like 2.5.
doses. Yeah, tiny doses.
Yeah, I mean, half of a 5 milligram tablets. I mean, it makes a huge difference for a lot of these patients. But you make a good point. So many of our hormones, especially the ones that come from the adrenal glands, and some of them that come from further up on the HBA axis, but they have their own circadian secretion, right? Some are diurnal. And that's important. But if we're not following a circadian kind of rhythm, then all of those hormones, their secretions and their function, by the way, are all altered.
Right.
All altered. It's hard to say.
So
it's super important. I completely agree. And then even in terms of just diet, so not only the foods that we choose to eat, which play a major role, but when we choose to eat them and how much we choose to eat them. But I always say with the new craze of intermittent fasting, people like to fast in the morning because it's easier. They're not as hungry in the morning, and they just find they can occupy themselves a lot easier and not eat. But I try to, and I'm okay if patients want to start that way so they can get sort of how it feels to sort of be a little hungry and be okay with it. But because eventually that seems to subside. But I always say that intermittent fasting is best used to follow the circadian rhythm, which is that we're not supposed to be eating large meals towards the end of the day when our bodies are trying to wind down into a more parasympathetic state, which will allow us to fall into slumber. So I try to sort of say, have your largest meal before 3, and then maybe a smaller meal at 5, and then just stop eating.
Right. I'm a little concerned about intermittent fasting. I mean, I think that the data on fasting and intermittent fasting as an immunologically effective treatment is overwhelming. But I'm concerned with our patients that if they do that, they will become even more protein deficient, vitamin deficient, et cetera, because so many already struggle with food. And degrees of malabsorption because of
Right. I guess I'm having this
dysmotility.
Conversation with the assumption that they've already been treated for the SIBO, they've been treated for mast cell, and so maybe they're at a more stable point. But you're absolutely correct.
Right.
I mean, obviously, if you're already struggling getting enough foods and with enough bioavailability, we certainly don't want you to suffer any further from a nutritional standpoint. Also, I should point out, clearly, trigger warning for anyone who's had eating disorders in their past. Like that's clearly not something that we're referring to, but just trying to sort of get the immune system sort of back on track so that the body is a little bit more resilient and has a little bit more grit to it, right? So that it can handle this inflammation that these patients suffer from. So I think that diet is an important focus. The sleep is an important focus. And movement, exercise and movement, and those and these are all goals. And sometimes I just sort of lay it out for patients, like this is ultimately where I want to see you, and if it takes us, a month, 6 months, a year, then that's okay. Yeah. We'll do it slowly.
Right, do it slowly, do it progressively, and to use to combine this a little. It's one of the reasons I'll suggest to patients start walking a little bit outside. Okay, take your gradually progressive pacing exercise outside so you get the sunlight, you get what's left of fresh air and things like that, because it's more than one benefit in terms of the activity. So those are lifestyle things. Yeah. We obviously talk on and on and on, and there is tons of really important literature on it. Then there's the world of supplements, okay? And it's a big world. I mean, it covers lots of stuff.
It does.
And there's always the sort of disclaimer. There's always the concern: are the supplements pure? Is there quality control? Where are the materials coming from? Are there contaminants? All those things are true. Having said that, one of the things I've been fascinated by is the number of patients, if you run the testing, who are vitamin deficient. Not just D, which we all know, and which, by the way, is hugely important in immune function. Okay, so for me, that is one of the first things to look for in a patient. And the number of patients I meet who come in and they're a mess, the usual MECFS long COVID picture, and I do a vitamin D and it comes back 14 or 12 with a goal of 70. It's unbelievable. And that has many, many adverse roles, and it's easy to fix. It's like a penny a pill. Okay, Same with vitamin C. If you measure the levels, how people get vitamin C deficient in our culture, where you walk into a supermarket and you have 9 million choices, I'm not sure, but they are. And that's very dysfunctional for your immune system. So I do run that whole panel, and I correct them. I didn't do it in the beginning because I thought it would basically be a waste of money.
Right.
But I've since learned that it should be done because there's so many deficiencies that I wouldn't have anticipated.
So what are the vitamins you test for? Because I don't do a whole lot of vitamin testing.
I do C, D, B12, folate, B1, B2. Yeah, those are the ones I do. I don't do E and K and B3, which is niacin, because I haven't found them helpful. It's harder to interpret those results. And if we have any listeners that have other thoughts, I'd love to hear it. I'm just not sure what to do with those. But it's very helpful to check those.
Because there are those nutrient panels, in those in private lab kits kind of thing. And I've run them a couple of times, and and sometimes I find some deficiencies, and I'll recommend repletion. I'm not so sure how reliable those tests are.
I don't actually run them at all. I just use Questor Lab core levels.
And you just do those vitamins that you mentioned.
Yeah.
Well, those are the important vitamins for sure, obviously, especially when we're talking immune function.
Right, and key to immune function, they're all key, but certainly D, C, folate, and B12 are huge.
I think a lot of it has to do with the gut lining and sort of this SIBO and some of the metabolites from the microbiome can contribute to abnormal mitochondrial function, which then can contribute to abnormal immune regulation. Right. So I think there's a lot of interplay, of course, and I think it's a lot more complicated than you need more vitamin D.
Yeah, exactly. I mean, it's part of
because we know that the receptors of vitamin D also, there's a lot of polymorphisms of those vitamin D receptors, and so sometimes if you cannot replete it enough, despite the fact that the patient is doing so much supplementation, but the levels aren't going high enough, sometimes you have to look into a little bit of genetic testing almost, some of the polymorphisms.
But it speaks to a theme we've had all through these episodes about the interactivity and bidirectionality of all these problems. Yes. And here, it may not be that the patient isn't eating well, it's that the bacteria in their small bowels gobbling it up before they get to absorb it, or because their dysmotility affects the bioavailability, or they simply need more. I mean, maybe in these illnesses you need more vitamin D, and so you chew it up, and therefore it's hard to maintain the level.
That's an excellent point, actually. Maybe the illness itself is sort of taking up all these vitamins. But as we both know, I mean, vitamins are substrates and cofactors for all the enzymes of our bodies. And so if you have a chronic inflammatory state, then you have presumably more enzymatic activity, which needs their cofactors and substrates, which are vitamins. Right. So so that does make sense why they are often so depleted in a lot of these vitamins. But it also is related to, obviously, the amount of food that they can tolerate, because mast cell patients often...
Right. So it's a vicious cycle. It's a vicious circle or cycle? Vicious
cycle. Vicious cycle.
Vicious cycle. But it is. It's like what we said about exercise and everything else. If I were a patient, I think I'd wake up constantly saying, it's not fair. I know what I want to do, but I can't do it.
It's not fair, though, right?
No,
I mean, I've had patients who've had food repertoires of 3 foods that they can tolerate.
Yeah, mast cell patients?
Yeah. I mean, it's insane to me.
Yeah, no, I know. My first mast cell patient could only eat 2 things.
Yeah, it's crazy.
It's amazing.
I know. Chicken and broccoli was one patient I had. It's all she can tolerate, chicken and broccoli. And so it's exciting when all of a sudden they can tolerate some more foods, right?
So moving from vitamins, there's minerals.
Minerals. I love minerals, though.
And again, I have to confess, I was not and still not very well educated in this stuff. I really had to learn it on my own. This is not stuff taught in medical school. It's a joke in medical school.
No, I don't think we mentioned minerals in medical school.
Well, and the only vitamins you mentioned was B12. I think the only vitamin I remember from medical school is B12. Okay. Yeah. I learned a little bit more during my HIV medicine days, but my education is terrible in this, and I've really had to learn it myself. And it's, for me, it's been one of the great values of Masterminds, our listserv. There's a couple of people on there who just know so much about this.
Oh, my
and
God.
I learned so much from it.
I'm so fascinated.
It's incredible. So minerals.
I always think, where did you learn this
I know.
stuff?
Not enough hours in the day.
I have this pad, not just to segue for 1 second. I have this pad where I list topics just from that listserv where I'm like, I have to read up on this. I have to look into this. I have to research this.
I'm worse.
And it's like this whole list of topics.
See, that's the way you should do it. I have these stickies and Post-its all over my goddamn computer, on the desk, on the rim around the computer. And then I use stickies in the computer, you know, that application. You should see if you open up the stickies what my computer looks like. I should do it your way. Anyhow, so minerals. So, I mean, there's a long, long list,
Yeah,
but, you know, the ones to look at and consider, let's take a relatively easy one, magnesium, okay?
So
Magnesium
critical.
isn't just a mineral. It is a cofactor in, I just heard the number in that a TAMA, like 300 different key metabolic enzymatic processes. It is a cofactor, and without it, it ain't going to happen, or it won't happen well. So magnesium's huge. Copper, zinc, iron, obviously, separate issue in some ways, but iron. What else?
Selenium is one of my
selenium,
favorites.
iodine, right? I mean,
there's
they should be checked. Part of the problem is it's hard to know how to check them well.
Right, and I don't know if you can rely on the assays that do check them.
Right. And I'm beginning to think that it's not worth checking, just replace.
I agree.
Because there's probably no downside, except for iron.
Well, iron is a downside.
You know, too much iron is not good, but I think the others, you know, as long as you do it wisely, it's not a problem.
I completely agree. And I have these mineral tinctures that I just put in my waters, in my teas. Just to have my own mineral source. But I agree, minerals, again, those are also cofactors and substrates. So not only vitamins, but minerals. They're very important for everything that goes on in our body, for sure.
Yep.
And so for our patients who are just chronically ill, it's even more important to make sure that they are getting enough minerals and enough vitamins. And that can be repleted, of course, by supplementation. But it can also, once we get them tolerating foods, you can get all of these things from whole food sources, which obviously is preferred, but that takes a while for our patients to get there, and I completely understand that.
Right.
But it is preferred. I mean, the body, in terms of bioavailability in general, the body really does prefer these things from whole food sources.
That is true, but again, if you look at the aging literature, even in older people who are not, quote, sick, who eat a good diet, the levels of these things start to go down. They don't seem able to use them as well, so you need higher levels. You know, and it's an area, again, in mainstream medicine that's always been like kind of not ignored, but skeptical about it. Whether we really scoffed. Yes, that's a good word. But again, there's another recent, I think it was 30,000, you know, people over 65, and they did were able to look at the value, in quotes, of a multivitamin with minerals, just that, and the impact that decreasing the incidence of certain diseases and dementia and stuff like that.
Right. So I'm not a big fan of the multivitamin thing.
No, I understand.
I think targeted therapy is more important than taking these multivitamins, which I don't think you can't say that it's got all that it says that it has in it, especially not at the dosages that it states so on the label. And then the other thing is you can't really manage any particular vitamin or mineral
it's
all
like
that
combo
well.
drugs, same problem.
And I've always found that multivitamin, I think that's a little bit of a scam,
yeah.
frankly.
I get, this is a little along that line. Most new patients that come in have a 1 to 2 page list of supplements they're taking, and not just vitamins and minerals by any means. And I always question, why are you taking all these? And could these be causing mast cell activation from excipients? Expedient excipients. And could they be interacting? Could they be causing other problems? And how the hell do you take so many pills in one day?
Yeah, exactly. Don't you get tired of swallowing all these pills?
Unbelievable.
I get the convenience of multivitamins. I mean, believe me, I totally understand the convenience, but I don't think it's the appropriate way. That's why I sort of like the idea of testing to sort of know, at least initially from the outset, what you truly are depleted in, right? So what we need to focus in on. And then maybe eventually you need to be on a lot more, and then maybe a multivitamin makes more sense. But I really just don't trust those multivitamins at all. So I like a very targeted kind of therapy. And I also, again, I think for just natural aging purposes, I think all of this works well. I worry that with our chronic patients, it's like a drop of water in the ocean, right? It's just not enough.
Oh,
and
yeah,
we need to go more and go the extra.
Okay, so that's a good segue into leaving over-the-counter supplement world to pharmacologic interventions.
Yeah.
So for me, the first one is low-dose naltrexone. We've
Love
talked
that.
about it before, I think. We have never done a whole episode, I don't think. But, I mean, low-dose naltrexone has multiple levels of activity. But at the end of the day, it modulates the immune system, improves its function.
I have to just say that yesterday when we saw that patient together,
Yeah.
your explanation of why we were recommending low-dose naltrexone was second to none. I was like so
thank you.
impressed with your spiel on LDN. I'm going to steal it. So give that spiel, go.
So it's this little 4.5 milligram pill, and I have patients that improve with 0.5 milligram. It reduces inflammation in the brain at the level of microglia. It modulates the immune system, meaning it helps rebalance it, helps restore homeostasis, helps reduce autoimmune phenomena in the body. I mean, it's through toll-like receptors. We don't have to get into the biochemistry. It improves gut motility, which is, in 80% of our patients, it's part of the game, part of the problem. And amazingly, it helps with pain. I have patients whose pain just disappears. I have had, not a lot, but I've had patients who say, all I need is the LDN, I'm fine. My pain's gone. I feel so much better. So it's an extraordinary drug. And we may not think of it, you and I and patients and other doctors, as an intervention to improve immune competence, but at the end of the day, that's what it's doing. Keeping in mind that anything we do that reduces inflammation will improve our immune competence. Okay? So LDN's a no-brainer. Every patient should be on that or try it at least. Okay. What else? Drugs.
Stabilizing the mast cells, right? Because all those inflammatory mediators come out of those mast cells.
Right.
And so while I think obviously antihistamines are fine, it's just one mediator that comes out, and it's, and so I think that stabilizing the mast cells is the most important thing, and we've discussed that, I think, ad nauseum.
Yeah.
I think our listeners are tired.
Yeah, I agree. I agree.
Stabilization.
So there are other drugs. Why don't we talk for a minute about the illegal peptides?
Oh, the illegal.
So my favorite, as
right, but
yours,
what's the point if we can't even order them anymore?
Because it's still too important.
Yeah, right.
And I learned this all from you, okay, is thymosin alpha-1, TA1. TA1 is an extraordinary drug. It's just amazing. And it still boggles my mind that the FDA banned it because they actually approved it as a drug.
I know.
It's approved. I actually had a meeting, excuse me, with the chief medical officer of the company that makes it as an approved drug to see why don't you bring it back to the country, The value of TA1 is phenomenal. It improves natural killer cell function, which is, if we never find a biomarker for ME/CFS, we're going to have to admit that natural killer cell function deficiency is the biomarker. Every single ME/CFS patient has a deficiency in abnormally low NK function measurement. This drug improves it. It improves NK function, it improves NK number. It has potent antivirals. It's been proven to be effective against the hepatitis viruses. I've seen it help. I can't prove it, but with chronic EBV reactivation, it's just an amazing product. Helps with fatigue. And I'm sure there's a dozen other things. I mean, it has B cell and D cell.
Peptide that we've gotten such great, but that's been banned for much longer than the more recent.
I know.
I haven't been able to prescribe that in over a year.
I know. It's just, it's infuriating. So, I mean, maybe we shouldn't spend time talking about it, but I can't help it.
it's just, I always don't want to, sort of give lots of credit to something that's been so helpful where I can't give it to patients.
Well, I mean, patients still get it, but they're getting it through the internet research-only pharmacies.
Right, but I'm not so sure how I feel about that.
Yeah,
exactly.
I agree.
So I don't want to sort of support that kind of, Anyway,
I agree.
But I agree with you. The peptides have really been game changers for a lot of our patients. And the fact that the FDA has taken that away from us is really problematic. Because whereas those would be my go-tos, I now have to think about what else I'm going to do. And that's upsetting because it's sort of interfered in how I've worked with patients and how I've helped get them feeling better. But we'll find other ways as we do.
Right.
That's what we do.
So other drugs, which I think maybe we won't go into in detail now, are rapamycin, which I've mentioned several times, spermidine, which is another kind of over-the-counter version of rapamycin. What else? I think those are the main ones.
Yeah. Okay.
The SGLT2 drugs. Is that I never get the initials right. Is that one Jardiance and
I saw that recent thread. I'm not as familiar with that drug class.
Yeah, so that's another class that's involved in insulin sensitivity and glucose intolerance
Right.
that has actually been shown in the aging trials to reduce inflammation and slow down aging. So I think it's actually something to consider in our patients. I use metformin based on some of that data, but I'm beginning to think I should probably switch it over to these drugs. And now maybe we could dive into.
I've been recently becoming a big fan of Actos. Did you ever use that back in the day?
No.
So there's a lot of interesting literature on its protective of the mitochondria. Actually,
Is that pioglitazone?
Yes.
Yeah.
Exactly.
Yeah.
And as you know, there was a patient of ours that I wanted to start it on, but it's contraindicated when there is the presence of type 1 diabetes.
Right.
It's used, of course, for type 2 diabetes, but it's contraindicated in patients who have type 1 if you want to use it off-label for other reasons. But there's really fascinating research about its protection of mitochondrial function and its support of the electron transport chain and its ability to reduce inflammation. And so I've started to sort of consider that drug for some of my more chronic ill patients that have not responded to some of the usual measures that we do. Anyway, I'm thinking that it's interesting that a lot of these classes of drugs are sort of in the line of, glucose metabolism and insulin sensitivity, and
Well, so again, that ties back to the aging. All right.
Exactly. No, it makes sense.
If you read the literature and you listen to the podcast and you think about it, aging is chronic inflammation, and chronic inflammation is probably being driven by insulin resistance and glucose intolerance that gets progressively worse as we get older.
Absolutely, without question.
It's just been shown over and over and over, and it's led to all the repurposing of these drugs.
Right.
I mean, to think about that, you're going to use a diabetes drug to slow down your aging.
Well, I think this all started with the whole GLP-1, like the Ozempic,
Well, but it was going on before, even before that. But I bet Ozempic will be another anti-aging
I'm sure
drug.
it will be, right? Reduction of weight alone is anti-aging, right?
Yeah.
The reduction of the ability for cells to be glycosylated and damaged by all of their circulating glucose is clearly going to reduce inflammation and prevent aging of cells. So I agree. It's so fascinating what's now on the horizon that I think are going to open up a whole lot of options for our patients.
It's so exciting.
It really is exciting. And then maybe we don't have to go to some of those more toxic immunosuppressant kinds of drugs that we have been using, frankly, which we're not going to discuss right at this episode, but we will discuss another episode. But even just when I think about all of the immune checkpoint inhibitors and the JAK kinase inhibitors and, the monoclonal antibodies even, and all of and the anti-proliferatives, which the anti-calcineurin, all those immunosuppressant drugs, which have their own toxicity profiles and things to worry about, maybe we won't have to go there.
Yeah, I agree.
Which is why I like to start with the immunosupportive kinds of infusion drugs like the IVIG, and then of course the plasmapheresis.
Right.
So
I want to come to those in one second. But there's one other thing I just remembered that I wanted to say and forgot. It's important because I think most people and most physicians don't think this way. Infection is an immunosuppressive event. So that's contradictory because when we get infected, we mount an immune response, okay? So in that sense, and in certain clinical situations, it actually is an immune booster. It improves immune competence, and if you look in the historic literature, there have been, I think I may have said this in some other episode, work done where doctors, this is 100 years ago, 75 years ago, would make their patients sick with infection. They would cause sepsis and their cancer would decrease because that septic event turbocharged the immune system to fight that, and that while it was turbocharged, said, oh, what's this? And it goes after the cancer, et cetera. So I'm not referring to that problem. What I'm referring to is EBV reactivation, tick-borne infection reactivation, which absolutely cause immune deficiency and immune dysfunction, to the point where I have patients who, depending on how long they've had their infection and their reactivation, their B cells, their CD19 cells go below normal. They develop IgG deficiencies, NK cell function deficiencies, and basically it's a kind of exhaustion. It's an immune exhaustion. The classic model, of course, is HIV disease, where you had this virus that infected the CD4 helper cell, and that number went from 700 to 10, and that patient went from healthy to deceased.
for sure. And these patients, when they get flu shots, if they get flu shots, and you sort of check the titers, they're all low, and they look like they're immunodeficient, but it's just because of their chronic infection.
Right.
They don't mount that immune response as they're supposed to. So vaccines aren't even as effective for these patients.
So I'm not going to get into a whole thing on infection. I just didn't want to lose the point that part of the way to try to improve immune competency is an aggressive search for ongoing infection and managing those infections.
Absolutely.
IVIG, finally.
I mean, I like IVIG, frankly. I think it really does. It does a lot of patients a lot of good. I think it has a lot of benefits. It comes with a lot, it can be hard to tolerate. So IVIG has been around, 50 years, 60 years, 1950s, I think.
Right.
So that's a long time. And, initially it was always pooled from donors, hundreds to thousands of stuff. And initially it was only in intramuscular form, and it was very painful.
Yep.
And you couldn't get very high levels, but regardless, they saw that there was benefit to those who had antibody deficiencies, that there were fewer infections.
Right.
And then there were some autoimmune kinds of concerns that they had noted that it was effective for. And I forget specifically, but not more of the common autoimmune diseases now, but some things, I think alopecia was one of them. But and so then it was seen to also treat autoimmune disorders. And over the years, over the decades, they've really, improved the formulation of IVIG, so that it there are standards that it's supposed to hold, that it's obviously not supposed to have any viruses, and there's a lot of safety standards that have been put in place. It's supposed to hold its function with regards to immunoglobulins, which is like opsonization, Fc receptor and complement fixation. So it's supposed to maintain all that biological function without, the impurities that the older formulations had. And it had a lot of aggregates because it would aggregate and cause a lot of reactions, and not necessarily, so back then it caused a lot of anaphylactic reactions, but because of the impurities that were held in it. So, but over the decades, it's really greatly improved. And in fact, in recent times, when I first started doing IVIG, I think there was just one option to be had. Like didn't really have a choice of brands. But now there are so many different brands that you can choose from, and they all differ. So they're not all the same, right? They all differ in terms of the distribution of IgG subclasses, the concentration of even immunoglobulin G, even the presence of immunoglobulin A. There's other different, even pH can differ, so aggregates can form at lower pHs,
and delivery method, IV versus sub-Q.
Of course, right. There's sub-Q, there's IV. And so so sometimes you really have to decide which brand you're going to choose based on the patient population. But I will say that there aren't a whole lot of distinctions from patient to patient to really make it clear that you would do better on this brand versus that brand, which just means that sometimes when patients aren't tolerating the infusion, after a couple of infusions, then you might want to consider change of brand, and then they will tolerate a different brand. And I think it has to do with a lot of different variables that I don't think we've really nailed down. Different formulations have different levels of sugar in it, so like sorbitol and sucrose and glucose. Different formulations have different osmolality, so which comes from the sodium content as well as sugar content and sometimes amino acids that are in the formulation. And so and the osmolality can cause a problem. Of course, you don't want it to be too many osmoles, as they say, which can happen when you're doing a highly concentrated formulation in a low fluid content, right? So it's too concentrated, and so you have the risk of having too many osmoles, obviously. So that can cause a lot of reactions as well. It can also be very dangerous. You want to be careful. And a lot of patients just don't want to sit there for a long period of time to have the infusion of a more diluted solution because it takes a lot longer. But sometimes it can be safer. And then you can manage a lot of these reactions, of course, with pre-meds and post-meds, and you do dilution, and I do pre-hydration, post-hydration. I add a lot of Benadryl and a lot of antihistamine
and steroids
can be very helpful. And so the goal, of course, is that you infuse these immunoglobulins that have their biological function, and then you are ultimately basically these immunoglobulins sit in places that autoantibodies won't be able to sit, right? So they sort of they cover up the receptors. And so that's how it helps autoimmune disorders. And then, of course, because of its biological function of opsonization and complement fixation and Fc receptor activity, it is very helpful for infectious disease, So it really helps to phagocytose the viruses and other, pathogens.
Right.
And that was always its initial function, but now it's being used more for autoimmune disorders, of course. And I find it to be, again, when you manage all these different things that I went through at, I know, warp speed, because I talk really fast. When you manage all these different variables, it could be very tolerable for patients and very effective and very beneficial, and it provides an immune support. It doesn't suppress your immune system at all. I don't want to say it boosts the immune system, although if you have an immunodeficiency, it does, obviously.
So I think it's important for audience, if they're not aware, that there's two kinds of IVIG treatment. There's immunoglobulin deficiency.
Right.
You run a panel of IgG subclasses. Their numbers are below normal. They're deficient. There are other insurance-based criteria to get approval, but basically it's, frequent infections and not responding properly to a vaccine. Right. And there's no other way to treat that. If you have IgG deficiency, you need IVIG.
Correct.
And the response in those patients can be remarkable, not just less infections, but their fatigue starts to literally disappear. They have more functionality, more energy, et cetera. That's the easy piece of IVIG.
Oh, that's an easy approval.
And it's actually pretty easy to get approved.
If you get the labs that support immunodeficiency, then you get an easy approval. Right. And it's the low dose, though.
I was just going to say it's like 1/4 or 1/5 of the dose for autoimmune.
Right.
For our patients, I think the majority, if they're going to need IVIG or get benefit, it's for its autoimmune efficacy. And that's a whole other, challenge to get approved, because there's only certain FDA indications for approval. And it is a much larger dose on the, if deficiency dosing is 0.4 grams per kilogram, autoimmune dosing, you start at 2 grams per kilogram. That's an enormous difference.
Yeah.
And those patients struggle. If they have mast cell, it can be really a huge issue. But it can also be game-changing. My problem with it, leaving aside the misery of getting improved and the difficulty in tolerating it, is in the autoimmune group, they get better, but then they get worse again in between their doses. I have not actually seen any patient who was treated with IVIG in the autoimmune world who gradually was able to just stop and stay well. And that's part of the reason I got involved in Rituxan, because, they're in between doses. So if they're getting it every 4 weeks, which is the traditional way, I don't think you do it. I don't do it that way, but that's the initial traditional way. After 3 days after the first dose, if they don't have bad side effects, I feel great, so much better. My joint pains are gone and my fevers are down and everything's better. Come the end of week 3, the beginning of week 4, everything starts to come back again.
Right. Well, that's when you increase frequency.
Right. But even my point is it gets rid of the antibodies, but they come back because they're being replenished by the B cells. It's not curing the disease.
Right. I mean, the idea is that over time you hope that the immune system sort of gets the message.
But have you seen that?
I have seen it, but it takes years.
Okay.
So, I mean, I've seen it in CIDP.
Right.
But not
where
always.
They get treated and then you're able to stop?
After years, yeah.
Okay. Well, you're a neurologist, so you've seen a lot more than me.
Well, myasthenia gravis is another example. Right. Over time, it does seem to produce fewer of these antibodies. If I gave it more, if I stop it and patients seem okay, then maybe in a couple of years their B cells are going to start creating these antibodies again, perhaps.
Right.
But I have seen it where it does seem to sort of retrain the immune system not to make those autoantibodies. I do think it's very beneficial, and like I said, I think it's once you get them to tolerate it. I mean, once they do, it's rarely a problem. Like once you sort of figure out, and in fact, the first infusion is often very hard because it's a very viscous fluid. It's very heavy, right? So it's like sludge in the vessels, and so you infuse it, and it's like the vessels, especially with my connective tissue disorder patients, their vessels are already friable because of all the connective tissue within the vessel lining, and so they all of a sudden are being stretched and sort of just overwhelmed and burdened by this very viscous, dense fluid because of the immunoglobulin content. And so that is often the reason why the initial infusion is the worst infusion. Right. And patients will get something called aseptic meningitis, which is like meningitis, though it's not infectious, but it feels like meningitis, and it's the worst head pain you'll ever have. Right. But there's no treatment for it other than palliative, but it is self-resolving. And then, of course, they get flu-like symptoms and fevers and body pain.
And there is a not insignificant risk of blood clots.
That is true. Although
All
it's
right.
less than it was, right?
It's
So
less than it was,
early
and a
on,
lot of
was a
it based on
problem.
administration.
Correct. Correct.
And I'm sure you've experienced this. I have patients who come to me on IVIG, and they're getting 60, 80 grams of infused IVIG, which is a huge dose, in my opinion, increases the risk of clots and side effects. They're not getting pre-meds. They complain about how they feel, and they're not getting pre-meds. So there's the issue of how is it being administered?
Right. I agree. You have to take great care.
Yeah.
And it does take a lot of work at the onset, but once you sort of do that work and get the plan for that patient, there's actually very little work to be done because now you've got their regimen.
Once it's going,
they
it's
respond
going.
well, and you just have to do the renewals and that kind of stuff. And I do think it's very, very helpful. And so I like IVIG for that purpose, and it's been first-line treatment for a lot of autoimmune disorders, a lot of autoimmune encephalopathies that we see.
Yeah, I know.
And so I just wish the insurance companies weren't so difficult to deal with about it.
Now you sound like me. So with that said,
but then,
let's move to what's even better.
Plasmapheresis. My God, it has been such an amazing experience to sort of take these patients and give them plasmapheresis and see what happens. And I've learned that what happens is often very good. And often better than what they were.
So let me interrupt you for a second. So I think what helps patients understand why it's better is the other name, Therapeutic Plasma Exchange, TPE, because it is exactly that. You're removing their plasma, you're removing their blood, separating the red blood cells and the white blood cells, et cetera, from the plasma, basically throwing the plasma out, giving a little bit albumin and saline or whatever back, and the difference. You know this way better than me, so interrupt me any second.
No, you're doing
the difference between IVIG and TPE is you're not just removing those nasty autoantibodies. You're removing junk. You're removing proteins. You're removing old proteins that should have been gobbled up and recycled, which is systems we have in our body, but it's not working because of your chronic illness and your chronic inflammation, et cetera, et cetera. And it's basically cleaning the field.
Right. No, you make an excellent point. And I should add that with IVIG, one of the concerns, of course, and while I will say the purification and the modification technology has gotten really great these days, you always worry about what else you're infusing. So there are no blood products in it, that we know, because that's been evaluated. But you do worry about what other antibodies are in there, for sure. You worry about other kinds of proteins and amino acids and things, because the purification and the different methodologies are only as good as they can be. And, they're not regularly checked. So you're not removing anything. If anything, you're adding things you don't even want to add. You might even be adding antibodies to certain infectious organisms.
Or creating antibodies.
Right, exactly.
Body mounts an antibody response to foreign junk.
That's exactly right.
Yeah.
So
sorry.
No, but you're right, because there could still be impurities left in the IVIG formulation. You don't really know. I mean, you obviously trust and rely upon the companies that say there aren't, but who knows? Right. The nice thing about TPE and or plasmapheresis, or PLEX, as they also call it, plasma exchange, is that you're not infusing anything other than albumin, which is the normal protein of the blood, of the body, I should say, not the blood, but of the body. And so, but otherwise, that's all you're infusing. And so you're removing the plasma, and in the plasma contains obviously autoantibodies, because the primary indication for plasmapheresis is autoimmune disorders. So there are autoantibodies present, but it also removes a lot of these inflammatory mediators that come from the white cells. It removes circulating viral RNA. It removes a lot of stuff that's just creating inflammation in the body, and that's what's so fabulous about it.
And that's, for me, I mean, again, you have more experience than me. I haven't treated enough patients yet, but it's so much more comprehensive and likely to be dealing with the underlying causes of illness in our patients than simply IVIG.
I agree.
Because it's removing to simplify it in a sense, it's removing all of these inflammatory mediators that are just constantly causing trouble. And it may not be permanent, like IVIG, the B cells may replenish the bad antibodies, but those bad proteins don't come right back.
That's right, they don't.
Those are more a function of time, and if you clean up your act,
right. So
it's
if we go back to the beginning of this podcast and talked about all the things that you can do for your immune system, if you're doing them and continue to do them and do plasmapheresis, then you actually have a chance of a sustained response.
And doing that will improve your immune competence.
For
Because
sure.
your immune system,
100%.
I mean, to put it in sort of simplistic sense, in these situations, your immune system is wasting its energy just trying to keep up with the mess that's going on, and it's not able to deal with the other things like an
Right.
infection or whatever, and while doing that, it's constantly causing inflammation.
That's exactly right.
So,
No, so the side effects can be because where there's a shift of fluids, right? So
right,
especially after the first and second one, there's a little bit of shift of fluids, but over the course of the treatment, you could have what's referred to as a negative fluid balance until your body sort of replenishes more fluid, or you consume more fluid, or get IVs. So that can cause feelings of fatigue sometimes, feelings of nausea,
right,
feeling like even dizziness kind of thing. But that's temporary and usually tolerable, and usually we can manage that. And the other thing, it could drop, things like fibrinogen, it can drop your hematocrit. So we just monitor all those with labs. We have not seen any really significant problems at all. But all of that is just temporary. And then, what's more sustained that you start to experience the few weeks after the full protocol, which is technically 6 sessions. There is such an incredible response with regards to decrease of POTS symptoms. Energy levels come up, improved sleep comes up, more food tolerances, or are able to
sure,
expand that food repertoire so that they can hopefully choose more healthy foods to once again contribute to immune competence. So there's such a great effect. And then, the question is, well, how long will this last? And I think the jury is a little bit still out. I mean, we've had patients who are months later are still experiencing those kinds of benefits. And so, and again, apheresis sort of came on the scene. Oh, first of all, obviously, it's an FDA-approved treatment for autoimmune diseases. We've been using it for decades. It used to be in the hospitals. I mean,
right.
I can go back through the history of plasmapheresis. I mean, not really, because I'm not a historian. I don't really know the history. But I could tell you that when I was first practicing, it was really this huge machine that was like a dialysis machine, and it was only inpatient.
Right.
So you had to get nephrology on board because they needed certain fistulas for particular access. Technology has advanced so much where it's now outpatient machines, and all you really need are peripheral lines. Obviously, if you have a port, it can be used as well. You can't really use a PICC line. It's got a lot of pressure, and it needs a large gauge that's tunneled in. But still, we can just use 2 peripheral lines. So it's really a lot more accessible to so many more people, which is so nice, right? So then with COVID, apheresis, of course, came on the scene because they were doing HELP apheresis specifically to remove the clotting that COVID seemed to cause with HELP apheresis, which is not available in this country, which I don't really understand why. It's not illegal, so I don't really get it, other than
Probably
they don't sell it to anyone in the United
FDA
States.
process to get approved.
Exactly. It's probably the FDA. Let's just blame everything on the FDA.
Well, I mean, the FDA serves a very important role.
Of course
but,
it does, yeah.
But it
it
does make it
does get
hard
in
to
the
bring new
way.
things in, especially
Sure.
if you're not Pfizer or Merck. So really, I mean, that's part of the issue.
I completely agree.
Yeah.
So, but I think what's important to ask is that, all right, so why does COVID put you in a hypercoagulable state? And it's likely because of these, mediators, right? So there's the cytokine panels now that are done. And so I think that we're removing some of the things that have created the milieu for those clots to easily form, is the theory that we're trying to prove, and others are trying to prove as well, that there's lots of people doing apheresis for long COVID. And it is a really effective treatment, I have to say. It's pretty amazing.
Unfortunately, there's limited approvals for it, FDA approvals, which means limited insurance coverage. The sad irony of that is that from a strict cost-benefit perspective and effectiveness perspective, it is so much more effective and much, much less expensive.
Much less expensive.
Because every month of IVIG can be $20,000, right?
Easily.
And you may be doing it for, as you just said, years. TPE is going to be a quarter of that per infusion, and after 6 infusions, you may be done.
Yeah, you're done.
You may be done.
Yeah.
You may recur a year later or something, but that's still such a difference in price.
Such a difference, and time, and energy.
Yeah, and effectiveness.
Right. And so, the questions that we're trying to answer is, how many do people really need to have that first great response? It seems like 6 is truly a good number, but I'm finding that patients are feeling benefits at 4 and even 5. I always explain that you can't just do 1. because things love to marginalize, things love to stick to vessel walls. And so it's, that first one, you're sort of removing everything that's just sort of circulating. And then once there's sort of room, in the middle
Right.
of the lumen, then things from the walls like to sort of jump into the pool. And now you still have more circulating stuff that are causing problems. So it's that second session where you sort of pull out the rest of the crud.
Sure,
the
sure.
gunk.
It's not a light switch; it's a dimmer
No,
switch.
right, exactly.
But it's a faster dimmer
That's a
switch
great
than
way to-
IVIG.
You're really good at those kinds of like metaphors and analogies. And so it's really after the third session that people are starting to feel the benefit. And certainly seems to be at the fourth session is like, wow. So I still think that 6 seems to be a good number, but I know it becomes expensive. And
Right.
so I sometimes tell patients, like, just do 4 and see how you
Right.
feel. And we can
Right.
always think about the other 2. And by the way, it doesn't have to be done in the same like visit. Like you can come back in a few months
Right.
for an extra few sessions
Right.
kind of thing. So, we're still trying to answer all those kinds of questions because insurance won't cover it. And I'm trying to get it to be more accessible to patients. So it's not breaking their bank, which, is obviously it's hard to do because it's expensive no matter how you look at it.
It's the
long
equipment,
treatment
and the disposables and the staff
for
make
sure.
it expensive.
Yeah. But if I can limit the number of sessions, at least that might help a little
Right.
bit. Anyway, so lots of questions to still answer, but only in regards of like, well, how many do I need? How often will I need them?
Right.
How long lasting will this benefit be? But whether or not it's been helpful for the majority of patients thus far, it has been helpful. And I think that's the most exciting point. And you're right, and we can avoid the IVIG. We give a little IVIG afterwards just for immunoglobulin
Right.
stabilization because
Right.
it's removing some. So, but it doesn't truly leave you immunosuppressed because it loves to remove immune complexes as opposed to just sort of free-flowing
Yeah, it's doing more
immunoglobulins.
than the IVIG.
Yeah.
That's the bottom line
Yeah,
to me.
absolutely.
Much more and much relevant to our patients. Much more, and
Right.
not to be quasi obsessed with this of this analogy or relationship. It is also very big in the anti-aging world
Longevity. Oh my
for
God.
exactly
It's
the
huge,
same
yeah.
reason that we keep talking about.
Right.
There's a physician who's about to present a study
Yeah.
this weekend,
Yep.
right?
This weekend.
This weekend,
Yeah.
of how it affects longevity.
Mhm.
All right, and it's for the same reason. It's removing all of this chronic inflammatory garbage
That's
out of
exactly
our blood.
right.
So I know I keep making that relationship,
No,
but I think it's important.
a very important relationship because you're right. Our patients are just they're just aging at a rapid rate is how we see it.
Right.
I will say the difference in the populations, though, of course, is that those that are interested in longevity but are healthy have a lot more disposable income. It
Of
seems
course,
like there's a
of course.
socioeconomic line here.
Totally.
And so, yes, you're right. In the longevity world, they're using plasmapheresis all the time.
Right.
Because it is removing those mediators that seem to contribute to cellular aging. But it seems like those people can afford it a lot more than our patients can
Right,
afford it.
right,
So
right.
it's an unfair. It's one of those things in life that make me angry.
So I think we're going to have to wrap it up. We did not really cover in detail things like rapamycin, exosomes,
Right.
some of the other
Well, we can do that next
interventions.
time. And plus, I do want to. Our next episode really should be about rituximab and the like.
Yes, exactly.
Right, because we do use a lot of those, and
Right.
and those are immunosuppressant, and
Right.
I would like to at least have our subscribers be aware
Yeah,
of
I think
those
that'll be our
drugs.
next episode.
Yeah. Okay.
Well, thank you. I
Yeah.
hope we didn't confuse people. I think we're a little bit all over the map as usual.
I don't
But
think
as-
there's a map that we
Yeah,
follow.
and as you can see, this is something Eileen and I are pretty passionate about, the role of the immune system and
For
its
sure.
its dysfunction leading to the illnesses our patients present with.
So thanks for joining us, and continue to join us. In the new year for 2024, we'll have a lot going on.
2024.
I know.
Okay, have a great holiday.
Yeah, happy holidays. But this won't post until,
Oh,
no,
yeah,
it'll,
right.
it'll be posted in time. Happy holidays, happy new year.
Whatever.
Bye.
Thank you.